I think it's fair to say that national policy in psychological practice in physical health is somewhat behind psychological practice in mental health. And so we really haven't reaped all of the benefits that we know we potentially can. I see this as the next big frontier really for policy development, but we're not there yet. So as a PPN nationally, what we're trying to do is really fly that flag. And so we've got a national event on the 15th of November in London. I hope many people will be able to be there to sort of help shape the narrative around this, demonstrate the impact and the potential, so that we can sort of help to push that next phase of policy development. But we currently don't have the modelling for psychological professions into physical health care that we have in mental health care. That's where we need to get to. It's going to take a huge collective effort and a great coalition of great people, some of whom are in this room, to help us get there, I think. So I think be assured it's in focus, but we've got some work to do. I think the more we can demonstrate the value, as we have already been seeing today, the more we'll win people over in that argument. And there are opportunities, I think. So we've got the major condition strategy. At the moment, that's a sort of interim report, and it doesn't really have money attached to it. But who knows where that will go in the next iteration of the major condition strategy. Perhaps there'll be opportunities there. And of course, we've got our psychological professions workforce plan. We can start building some of this into, so that that can hopefully influence the next iteration of long-term workforce plan. Those are some of the things.
And I guess from my perspective, and funnily enough, I remember having this conversation probably about 15 years ago around psychological input into physical healthcare services, is that it's also about influencing the service commissioners. So actually, if they commission a psychological input as part of a patient pathway for diabetes or pain management or whatever, then it follows and enables us to do that. So I think there's something around how you guys influence your service commissioners as well. But as Adrian says, at the moment, we're kind of led by where the money comes from.
Thank you. Give me a minute to set your hands to that. I think your mic's off.
Okay,
yes.
Mine was a very similar question, but actually just building on your comment just then, I think what's happening in our ICB is that clinicians are keen to think about having psychologically informed pathways and long-term conditions, and even have psychological roles in, but there's a bit of arguing about who should pay for them. Is that coming from the mental health stream and onto the mental health board, and they're saying no, it's not our business, it's long-term conditions, and long-term conditions are saying no, it's not us. So we're back to that kind of I guess local kind of bargaining around whose remit is this, and that might vary, I guess, between different ICSs, but certainly in Derbyshire, that's what we're finding is that local kind of dispute.
That's really unfortunate, isn't it? And one of the things I've seen cut through that sometimes is getting patients in the room. Maybe there's opportunities to do that.
Yeah, thanks, Rachel. I think we've got Charles.
Mine was going back to, hi, so mine was going back to the cultural and the language kind of frameworks and the competencies that are in the mental health field at the moment. Is there anything in the forward plan or anything to engage with that barrier?
So when you're talking about language competencies, are you meaning literally sort of translation of materials and that sort of thing?
Just a bit of context. So I've launched a service which kind of overcomes those language and cultural barriers. And a lot of the bilingual practitioners or the counsellors that we've got on board, like I'm just speaking to them because they're all freelancers. As I'm engaging with majority of them, and they're in different practices or they're working within the NHS, they don't have a foundation or a framework to work on when they're speaking to, I don't know, refugees, asylum seekers, youth that don't have that language barrier, or translating for their parents, for example. They don't have that, I'd say, framework really. So that's why we wanted to ask that question today. Like, is there some sort of like guidance? Because me creating it for myself and working with other practitioners is great, but then it's also good to have a soundboard of everyone else.
So the area where I know there's been a lot of sort of progress on this and action is in NHS talking therapies particularly. So we do now have a lot of the sort of guided self-help materials translated into the 15 most common languages in the UK. We've also got all of the sort of outcome measures translated into 15 different languages, nearly all of them. And it's common practice for there to be work through interpreters, and obviously where possible, people sort of speaking their first language in therapy.
I think that's the kind of barrier that I encountered because I was speaking to a few of the Sandwell and Dudley leads in the mental health field, and it was that thing about getting that interpreter in, but the thing is with the interpreter, one, the confidentiality goes out the window then, and then secondly, things get lost in translation. So the reason that I kind of focused and honed into actually getting those bilingual counsellors and practitioners in and just focusing on that niche was to overcome that, but then creating a framework that they can even use because they don't have that guidance from anywhere else, and creating it myself was quite difficult, so I thought I'd bring that and see if we can kind of collaborate and work forward to create a framework.
Thank you. I mean, one thing it might be worth you looking at if you haven't already is the Positive Practice Guide for Black, Asian and Minority Ethnic Service users in the NHS Talking Therapies programme.
Okay.
There's quite a lot of good content and links on this.
Okay.
And I think you'll find some links in there also to the sort of use of interpreters and best practice and some training resources.
Beautiful. What was that guide called again?
The BAME Positive Practice Guide.
Beautiful.
It's on e-learning for health, I believe, is it?
There's some e-learning on e-learning for health relating to it, but you can also get it from the BABCP website.
Beautiful. Thank you.
Thanks for that. And if you've got any issues about accessing some of those, because one of the challenges that we know is a lot of them are very NHS-centric, so we've got providers there, just email us at the PPN website. There, John, and then Luke.
Sorry, just jumping back to physical healthcare just for a second. I attended the excellent webinar that you did a few months ago on physical healthcare, psychological practice. Thank you. During the discussion, you mentioned that there was a discussion paper about to be released in July. I don't know if I just missed it. I haven't managed to find it.
It's still about to be released.
We have a date then, I
yeah. So
it's
it's literally in the final design phase, but it will be launched during Psychological Professions Week.
Brilliant. Thank you.
Thank you. I've lost track. I think it was John, then Luke, and then Judith.
So this question... Oh, thank you.
Sorry, just hold the mic when you ask the question.
Okay. For Adrian, it's really good to hear about the long-term workforce plan, and you said about future iterations might allow the psychological professions part to be more concrete in terms of the aims. I was wondering what you meant by that and what's missing at the moment, and was it about the numbers for different psychological professions, or and part of the context is we've got a challenge at the moment in our trust with safer staffing frameworks on the inpatient wards, and the need to have a certain number of nursing staff on each ward, and doesn't relate to psychologists, and yet we can't recruit those nursing staff, so we're a bit challenged by national frameworks, I guess, which trying to think through with it locally. But yeah, it was just, so that was the context, but I was wondering what you were thinking about how we might develop this.
So one of the gaps is in the education model. So the education model in long-term workforce plan only has clinical psychologists and child psychotherapists in it. We're not going to have 24 to 26,000 more staff by only having that in our education model. So we need the comprehensive education model across all of the roles. And so the next stage of it, I think, needs to have that comprehensive model. What we've got is a stopgap for 3 years, which is saying carry on doing what we're doing at the moment, which is training a lot of talking therapies workers, a lot of MHWPs. We've got apprenticeships such as CAPS, but that's not built into an education model in the plan. So that's a key gap. Safer staffing is an interesting one. I used to be a CPPO in Sussex, and I know that our Chief Nursing Officer did find workarounds that were consistent with safer staffing but allowed a broader, more diverse range of staff to be counted in the numbers. So it might be worth connecting with others on it.
Yeah, okay, thank you.
Thank you, John. Pass it back towards Luke. Can I send the microphone backwards towards Luke, please? Thank you. And then across to Judith.
Thank you. My question is about prevention, really. In the various iterations of the long-term plan and other documents by the BPS and HCPC, there's this idea about kind of psychologists working in preventative ways with third sector organisations looking upstream, really. And I wondered whether you could comment on at the plans to kind of support the infrastructure within the existing workforce to be able to work in that area. Often psychologists don't have training or expertise of working kind of with local authorities or in preventive ways. And so I didn't know whether there was any kind of plans for the future to develop training packages or additional training or courses that upskill the existing workforce, and for existing trusts to develop new posts that are kind of span between health and social care in a kind of preventative way, really. So that was my comment.
I was just kind of thinking. So, I mean, I think there is the development of provider collaboratives within systems, across systems, that actually do some of that support. In terms of a specific, I guess it's almost it goes back to the cultural competence bit, actually, isn't it? It's about making sure you're speaking the same language when you're talking to somebody in local authority. And it's something potentially we could look at on a regional level, if I can find some funding, because I think increasingly we do need to think about that multi-organisational working. I think that's definitely our direction of travel, isn't it?
And I would say I think that the narrative around prevention is much stronger than investment. And so, we need to look for where the opportunities are, where there's investment. One of those is mental health support teams, I think. I think this could be really thought of as an upstream new service that can really help as it continues to expand. But I think the sort of psychologists working in prevention and public health, it's still, really sort of not gained the momentum that I think we would need it to really sort of address the ambition that's in the long-term plan. But of course we have practitioners with great skills in that area. So, I'm thinking of health psychologists in public health, but many others as well. So I think at the moment it's grabbing the opportunities where they arise rather than a programmatic piece of work.
Thank you. Judith?
My question's about the CAPS role, and it just all feels really exciting. I just wondered if there are any plans for career ambition, for career progression for CAPS, either maybe sort of senior CAPS roles, or if there's like a competency-based model for them where they could then transition towards getting their doctorates, or I didn't know if there was any thoughts around that.
Yeah. So I think there's also huge potential in the CAPS role and great opportunities with it. I think in Scotland, obviously, there has been a sort of process of approval of prior experience and learning for CAPS into the doctorate. I think it reduces their doctorate by 6 months. We don't have that in England at the moment, but there may be potential, and I think some universities are starting to sort of scope that out and think about it. Career opportunities, I think there are many. I mean, obviously going on to the doctorate is one. Another great career opportunity, I think, for CAPS is to go on to one of the psychological therapy trainings that are currently available. So we know that some of those can be hard to fill because there's a shortage of suitably qualified professionals who have the sort of background competencies. I think CAPS have the background competencies. There's a great chance there for there to be a sort of very rounded practitioner produced who has specific therapy competencies of one of those psychological therapies, as well as the sort of broader formulation approach. So that's one of the opportunities. I haven't heard of the sort of senior CAPS role emerging, but there may be pockets of that starting to happen. I think the important thing there is to be clear, what additional training is needed for some of the specific competencies. So, for example, to be a CBT therapist, I think you need to do a CBT training, but there's no reason why CAPS can't enter those routes. Lots of possibilities, I think.
I think there's something about role enrichment as well. Not everybody wants to move up, but potentially sometimes there are opportunities to broaden a role as well. CAPS isn't something from a workforce training and education perspective. It's not a programme we've funded or done a lot with, so I'm kind of just, it's my personal thoughts really, but I think quite often that broadening of somebody's post and that role enrichment is equally as important as vertical progression.
Thank you for that. Any more? Jazz at the back.
Being greedy, yeah.
You are. That will be the last one. you.
Just hearing everyone's discussion about role enrichment and what the caps and stuff are and getting more people into the psychological field, has the PPN or any workforce plans being made to speak to, I don't know, colleges or university students that are going into that field? Because when I'm speaking to students across Aston University, Staffordshire University, for example, and being a mental health mentor myself, they don't know what's out there. When you're doing a psychology degree or when you're doing something supplementing with a psychology degree, they still don't know, okay, that's a pathway that could lead to it, or what are the options. And I think giving young adults, even mature students who are at university, those kind of pathways would then make them more confident in the role when they have graduated, and then would help, support, for example, everyone else in that community. So is there kind of discussions and stuff being involved there?
Yeah.
Yes.
So, I'd point to two resources. One is Health Careers, NHS Health Careers site, which has all of the roles on it, and so people can dig into that. The other one is we have a PPN career map that's interactive, and you can click into I'm a psychology graduate, or I'm another graduate, or I'm not a graduate, and see what the available paths are. That's currently being updated, but we have a version of it live at the moment on the PPN website.
And locally within PPN Midlands, we've got a number of career champions, so we've actually got a career pack that can actually go out to anybody that wants it. It talks about all the options that are available, and we've worked jointly with our colleagues, haven't we, Lawrence, within the British Psychological Society as well, to do events at universities and also secondary schools, to actually start building in that pipeline. So that's all there. Understand the PPN Midlands, this is me plugging our patch. Understand us as a connector. And actually there is a lot of work that's out there. But remember what I said, 11 ICSs. It's a massive, massive patch. So there will be things that you won't know about, but actually we could be a really good repository and connect you up. We're not in the business of reinventing the wheel. We are in the business of signposting and say, go look there, go look there, go look there. But actually there is a lot of work that is addressing a number of the issues that you have all raised today. It's just connecting up to you.
And quite a lot of the ICSs have, I guess, what you'd call kind of some sort of talent academy. Very often focused around apprenticeships and work experience and those kinds of things. But you are the greatest advocates for the psychological professions. So find out what your organisations are doing around plugging healthcare careers, and get yourself as part of that. Years ago, I used to run a scheme in Lincolnshire around ambassadors, and they would go into schools and talk about their profession and those kinds of things, because there's nothing quite like it than hearing it from somebody who does the job.
And on that note, I just want to say thank you. Thank you everybody for listening and for bearing with us. And thank you Adrian and Helen for your contributions. It's just, I just think it's invigorating and using it, and it just keeps my energy levels up to hear all of the interest and all of the passion that we all have about making things different from how they are now. So big hand for you too.